So, good afternoon. Good afternoon to all. Would like to thank you all. First, Dr. Fadi Farahat, the president of the CRG, and AMAC for preparing this ABC educational courses. As you know, that this courses is endorsed by UICC and ASCO. It's awarded by 2 CMEs by AMAC. Today, lectures will be about updates in hematology. For the persons and colleagues that wants to hear it in French, we have the simultaneous translation. Our President, Dr. Fadi Farahat, I will give you the floor to start presenting our first speaker. Dr. Farahat, the floor is yours.
Thank you, Dr. Sami. Thank you, Dr. Sami, our chairman. Thank you for the attendees. Thank you for the speakers, Dr. Colette Hanna. To introduce Dr. Colette, Dr. Colette is one of our eminent hematologist, oncologist in Lebanon, more specialized in hematology. We rely on her. We take her advices frequently. She's assistant professor. She's also in different hospitals in Hotel Dieu de France and others. Today she will give us an update about the CLL. Dr. Colette, the floor is yours, please.
Thank you, Dr. Farhat, for this very nice introduction. So maybe we can begin to share the screen. I think they will be sharing it from the side of Sciences Pro.
Vanessa?
And I can share it also. Yeah. Okay. No. Vanessa, are you here?
Vanessa, would you like to share the lecture of Dr. Colette?
Oh, if you want, give me, I will share my, okay. Very good. All right, so we will be talking today, in fact, about new updates in chronic lymphocytic leukemia. And as you all know, chronic lymphocytic leukemia is, in fact, the same entity than the small lymphocytic also lymphoma. So if we can go to next slide, we know that we have more than 21,000 estimated new cases in, for example, 2021 in the United States. And 7% of all the cases of non-Hodgkin lymphoma are CLL/small lymphocytic lymphoma. So as we said, it's the same entity, but one with the leukemic phase and the second with a nodal, in fact, phase. The median age at diagnosis is 70 years. But in fact, in our countries, and I don't know if you have the same, in fact, conclusion, we are seeing more CLL and small lymphocytic lymphoma at an earlier age. So it's not really 70 years in our surroundings. So small lymphocytic lymphoma and CLL are considered the same B-cell malignancy, and we will put the diagnosis or by having more than 5,000 clonal lymphocytes in peripheral blood, or by the presence of a lymphadenopathy and or splenomegaly, and inferior to 5,000, in fact, clonal lymphocytes in peripheral blood. The median 5-year survival is more than 80%, which means that this disease is indolent, and we have to make sure that we're giving the right treatment at the right moment, and not to over-treat our patients or to treat them in a very aggressive way and lose them by toxicity. Next. So this is a small cartoon inside, in fact, to make us always remember that it's a B cell malignancy, and in fact that we can have a lot of symptoms that accompany the CLL or the small lymphocytic lymphoma. It typically affects adults greater than 65 years of age, and it will manifest itself or by lymphadenopathy or by hepatosplenomegaly. And the most dreadful complication is the Richter transformation. So the Richter transformation is really a cataclysmic transformation for the CLL or the small lymphocytic lymphoma. And we tend to send them very quickly to allogeneic bone marrow transplantation if they transform into a Richter syndrome. So it is the most common type, we say, of leukemia in the West, but as we all know, in the World Health Organization, we are classifying, of course, the CLL as a lymphoma and not as a leukemia. Next, please. So these are the smudge cells. The smudge cells are typical in the peripheral smear of the chronic lymphocytic leukemia. And it's due, in fact, to the presence of so many lymphocytes. And when we put it on the peripheral smear, it will be like écrasé. And we will have what we call, in fact, the smudge cells. Next again. For the diagnosis, and this is, we can discuss it after, for the diagnosis, we can say that we have an absolute lymphocyte count superior to 5,000 with mature appearing lymphocytes, and you need, in fact, to have a flow cytometry. A flow cytometry on the peripheral blood, which will show a very special immunophenotyping, CD5 positive, CD19 positive, CD23 positive, with Ig light chain restricted, kappa or lambda. And this is what we call the Matthew test score, in fact. The Matthew test score, if it is 4 or 5, you are sure to have a chronic lymphocytic leukemia. If it is 1 or 2, you have to be careful not to have missed, in fact, a mantle cell lymphoma or, for example, a marginal zone lymphoma. For the diagnosis, a bone marrow biopsy is not required for the diagnosis if you can do, in fact, the cytogenetics on the peripheral blood. And now it is very important not only for prognosis, but also to choose your treatment, to do the cytogenetics, that if you have access to NGS, you would do it by NGS, or you will do the cytogenetics by FISH, which is another technique. And you have to do, of course, the IGHV mutation status, since it will direct your treatment. For the clinical course of CLL, the diagnosis is often incidental. They are asymptomatic at diagnosis and for a prolonged period. The initial symptoms, as we said, will be an enlargement of the lymph nodes. And do not forget that the spleen is one of the lymph node family, in fact, and they can present a lot with splenomegaly, with early satiety, and with a problem due to a huge splenomegaly that sometimes can go more than 10 centimeters of the usual size. We can have also anemia, and then we can go into full bone marrow insufficiency. And the anemia, don't forget that it can come from an auto. Very important when you have an anemia or an unexplained anemia, also to ask for the COMS direct, indirect LDH aptoglobin to make sure that we don't have hemolysis. You will have also a progressive hypogammaglobulinemia with advancing disease, and the long-term complication are the autoimmune phenomena and the Richter's transformation. So what about the autoimmune complications of CLL? For the autoimmune hemolytic anemia, the COMS is variable. You have a clinical hemolysis. You can have also a pure red cell aplasia. You can have an immune-mediated thrombocytopenia, a granulocytopenia, but the other autoimmune diseases are uncommon with the CLL. And as you all know, we have two types of classification, the rice system and the Binet system, which are practically the same. We will talk more about, in fact, the rice system, which is in fact stage 0, 1, 2, 3, and it will involve a CBC with the presence, in fact, of the lymphocyte, splenomegaly, hepatomegaly, anemia, or thrombocytopenia. And this is important not only for the prognosis of the patient, since it will give you a very clear idea and a very rapid idea of the prognosis of the patient, but also this is important because it could be one of your criteria to begin treatment, and we will talk about it. What are the prognostic factors that are associated with shorter survival in CLL? So as we talk now, it's very important to do cytogenetics. And to respond to Dr. Farhat, since he asked the question, I do the IGHV mutation at the diagnosis because it doesn't change, and I don't have to do it again, even at each progression. So it's a one-stop test, and it will not change throughout the time. So I will do it at the diagnosis of the CLL. And the FISH, I will do it if I have the financial access at the diagnosis and at each progression, since at each progression we can acquire the deletion 17p, which is our most dreadful mutation in this population. Also, and this is why there are some centers that continue to do, in fact, a bone marrow biopsy or aspiration, even when they don't have unexplained cytopenia in CLL. It's to go for the karyotype, but personally, we are not doing it when everything is clear by FISH and by the IGHV mutation, but some centers are still doing, in fact, the bone marrow biopsy for the complex karyotype. Very important also to have the IGHV unmutated or mutated. As you know, when it's unmutated, it's not good, and it has a worse prognosis, and you should monitor this patient more when you have an unmutated IGHV mutation. So these are the genomic aberration in CLL, and contrary to all the other diseases that we know, we have more than 80% of the patients that will present at the diagnosis with a genomic aberration. So the most frequent one is the 13q deletion, with more than 55% of the patient having a 13q deletion. Then you will have the 11q deletion, the trisomy 12, the 17p deletion, and the 6q deletion. And since we know that more than 80% of this patient will fall into these cytogenetic abnormalities, that's why we can, when we have no access to NGS, go by FISH and try to find at least these deletions in our patients, and this is to guide our treatment and to choose our treatment further on. So why is the 17p deletion is the most dreadful one? Because as you see here, whether you treat them or this is the probability of survival before, in fact, any treatment, when we didn't have any treatment available. But we know that the patient, whether you treat them or not, the worst prognosis is when you have the 17p deletion, as you see in the green curve. And the best prognosis will be in the patient who have the 13q deletion as a sole abnormality. So this is only by FISH you can practically define if your patient will live more than 5 years or less than 5 years. And this is very important for the patient to know, since it is a simple test that you can do on the peripheral blood. And normally we all have access to the cytogenetics by FISH, at least for the CLL patient. So this is to define the complete response in CLL. When we begin, in fact, to treat the patient, we have to know when we can define a complete response. You have, in fact, to have less than 4,000 of lymphocyte count. You have to have all your lymph nodes that are shrank to less than 1.5 centimeter and no palpable disease. And the thrombocytopenia, the platelets must be superior to 100,000, hemoglobin superior to 11, and the bone marrow, if you are doing it, is to have less than 30% lymphocytes. Very important to know now that in all the new studies, we are doing something called the MRD evaluation, which is the minimal residual disease. So the CLL, we are trying, in fact, to find, and hopefully it will finish like that, a cure. And when we begin to speak about MRD, this means that we are beginning to speak about an eventual cure for CLL. And it's very important now in all our clinical trials to have an MRD for the CLL, because it will tell us not only if we can achieve a cure in this kind of disease, but also it has a very clear prognostic impact on when the disease will come back. So if, for example, we give a fixed dose duration treatment and we still have an MRD positivity at the end of this treatment, we know that these patients will recur very quickly versus the one that will achieve MRD negativity. And this is very important to our further trials and also to guide our treatment. What about, in fact, indication to initiate treatment? Until now, we are following the same indications to initiate treatment for CLL, which are the constitutional symptoms, meaning weight loss, sweat, fever, etc., night sweats, progressive marrow failure, autoimmune anemia plus or minus thrombocytopenia, poorly responsive to steroids or other, a massive or progressive splenomegaly, a massive or progressive lymphadenopathy. Also, you have the progressive lymphocytosis, more than 50% increase, for example, over 2 months, or a lymphocyte doubling time inferior to 6 months. And until now, even if you have a high-risk patient, like with deletion 17p, or, for example, IGHV unmutated, until now, it is not recommended to begin a treatment if you don't have, in fact, a criteria to treat this patient, even if you have a bad cytogenetic or a bad IGHV mutation. So we have gone a long way since the 60s or the 70s, where we had the chlorambucil and cyclophosphamide, then we had the fludarabine, then you had the combination chemotherapy, then you had a chemoimmunotherapy, the FCR, then with the introduction, in fact, of the monoclonal antibodies, the anti-CD20. Then it was in the 2010, we had the small molecule inhibitor, whether they are inhibiting, in fact, the BCL2 or the Breton tyrosine kinase inhibitor, and also the BCR pathway. Sorry. So, okay. So this is the prognostic value of the fish, sorry, and we talked about it, but it's just a small table to make you see, like, for example, if you have a deletion 17p, your median overall survival will be of 32 months. Whether if you have a deletion of 13q, your median overall survival will be 133 months. And this is prior to novel oral targeted therapy. So if you have a patient coming with no indication to treatment with the deletion 13q, you can be practically sure that he will live more than 100 months. And this is very important for the patient to know, since it is a chronic disease. And the second very important mutation is the IGHV mutational status. When we have a non-mutated IGHV CLL or small lymphocytic lymphoma, this bears a worse prognosis than when we have a mutated IGHV patient. The other thing is also to know that we talk about the TP53 mutation, which will yield, in fact, the deletion 70p deletion. But sometimes we have some discrepancy between the fish cytogenetics that will give us a normal deletion, no deletion of 17p, but still we will have a TP53 mutation. And this can happen in 5% of the cases. But since we are in a financial crisis and since we don't have really access to doing the TP53 mutation in our country, we are relying, in fact, on the deletion 17p that is done by fish. So we have many frontline therapy options now in CLL. Ibrutinib plus or minus obinutuzumab, acalabrutinib plus or minus obinutuzumab, venetoclax plus obinutuzumab, ibrutinib plus venetoclax, this will be very soon, I think, FCR, and other chemoimmunotherapy. So the whole question now is, how do we choose between all these treatments in CLL? And the first question that we have to ask ourselves, are we done with chemoimmunotherapy? And the answer is yes, between brackets, almost, because young patients or young and fit patients inferior or equal to 65 years of age can still be considered for FCR. In fact, if they have IGHV mutated CLL and no high-risk genomic abnormalities. So this is the only niche where we would use, in fact, the FCR. And it would be interesting if we discuss, if you are using, in fact, the FCR, would you go for 4 cycles or 6 cycles if you achieve a complete remission after 3 cycles? Since we know that the FCR is a very good regimen, but it yields a lot of toxicity, especially, in fact, stem cell toxicity and infectious ones. So, technical problem. For the ibrutinib, we have a lot of key phase 3 trials supporting CLL, SLL approvals in frontline treatment. So we have the Alliance trial, which in fact compared first-line BR versus ibrutinib plus or minus rituximab in CLL. You have the E1912 trial, ibrutinib plus rituximab versus FCR in patients inferior to 70 years previously untreated. Illuminate trial, first-line ibrutinib plus obinutuzumab versus chlorambucil plus obinutuzumab, and the Resonate-2, ibrutinib in older patients with treatment-naive CLL, SLL. And as you all know, for example, we won't discuss every trial because we don't have, in fact, the time for every trial. But as you all know, for example, for the Resonate-2, which compared ibrutinib versus chlorambucil, which was the standard of care at that time, you can see that the PFS, the separation of the curves are spectacular. And you can see that the benefit of the PFS with ibrutinib was 90% at 80 months, 70% at 60 months, and 61% at 78 months, which was in fact really superior to the chlorambucil. And if we look here more closely at the 7-year follow-up of the Resonate-2 with the PFS mutated versus unmutated IGHV, you can see that the ibrutinib, whether they were mutated or unmutated, it had a good response versus the chlorambucil, where you see that the curves are separated between the mutated and the unmutated IGHV. And this can, maybe it can be a small indication when to use as a first line, as a frontline treatment, when to use the Bruton tyrosine kinase inhibitor versus, for example, the BCL2 inhibitors. Also, in the Illuminate study, we can see that ibrutinib plus obinutuzumab versus chlorambucil plus obinutuzumab in CLL, and the PFS mutated versus the unmutated IGHV, the PFS in older, unfit patients with unmutated versus mutated IGHV. And you can see that the combination made was better, in fact, than the chlorambucil plus obinutuzumab in the elderly patients. What about, in fact, the first line ibrutinib plus or minus rituximab versus bendamustine plus rituximab in older patients with CLL? And it was an international randomized open label phase 3 study. And we all remember the time where we used to have patients with a SEERS score that was superior to 6, or they had a lot of comorbidities, and we couldn't use, in fact, the FCR, and we used to do a chemoimmunotherapy with bendamustine rituximab. So they tried to give ibrutinib versus ibrutinib plus rituximab versus the BR, which was at the dose of 90 milligram per square meter on day 1 and 2. And remember that the rituximab, you give it at 375 milligram per square meter on cycle 1, day 1, and then you increase to 500 milligram per square meter on cycles 2 to 6. And in fact, they included untreated patients with CLL superior to 65 years of age with an ECOG performance status of 0 to 2, an absolute neutrophil count superior to 1,000, and a platelet superior to 30,000, and the creatinine clearance superior to 40. And the PFS significantly improved with ibrutinib versus BR, but the two curves of ibrutinib plus rituximab were similar. So it doesn't help, in fact, to add rituximab to the elderly patient versus, in fact, the BR. So you can give ibrutinib as as a monotherapy for this kind of patients. And if we look also closely in this study, we can see that the patient with a TP53 aberration, they respond poorly to chemoimmunotherapy. So these, we should avoid to give them chemoimmunotherapy, since we know that they will not respond, in fact, to this kind of combination, and they will get only the toxicity. Pardon. What about the acalabrutinib plus or minus obinutuzumab versus chlorambucil plus obinutuzumab in previously untreated CLL? They received also the approval for the acalabrutinib plus obinutuzumab in a frontline treatment. We don't have access until now in Lebanon for the acalabrutinib, but of course it is one of the first line treatments that are totally approved now and is used throughout the world. An important point also to take into consideration when we are using or choosing our frontline treatment is the toxicities that we can have with every pharmacology class. So if we have an atrial fibrillation with a BTK inhibitor therapy in CLL, we have a higher rate of atrial fibrillation in treatment-naive patient, and pooled safety analysis of multiple ibrutinib tribe documented new onset of atrial fibrillation in 6% of patients receiving ibrutinib and 2% of patients receiving comparator agents. The prevalence of atrial fibrillation were the greatest in the first 3 months, and then, in fact, it decreased over the time. But it's very important, and that's what we do every time, is in fact to send the patient that we want to put under, for example, ibrutinib or a bruton tyrosine kinase inhibitor to a cardiologist, which will obtain a baseline clinic risk assessment of cardiovascular risk factors before initiating therapy. And now we have a score, a SHAD-VASC score. And if we have, in fact, more than one risk factor or two risk factor on the SHAD score, maybe you will consider to go to another treatment than the bruton tyrosine kinase inhibitor. And if you are compelled, in fact, to use the BTKI inhibitor, and you have to consider a treatment for your atrial fibrillation, consider a beta blockade, often preferred as the first choice over CYP3A4 inhibitors, for example, the verapamil and the diltiazem, or the P-glycoprotein substrate like amiodarone, which can interact with BTK inhibitor. And if you want to do an anticoagulation strategy, the one that is more recommended is the low-dose apixaban, 2.5 milligram twice daily, given the CYP3A4 interaction and enoxaparin. And when possible, please avoid the combination with the vitamin K antagonist. And this is important for us to know because the cardiologist may be not aware of all these contraindications, and we should help him when we have patients with CLL or small lymphocytic lymphoma under bruton tyrosine kinase inhibitor. The second problem that involves also our cardiologists with the use of BTK inhibitor therapy is the hypertension, with a prevalence that increases over time. 80% of patients in the analysis exhibited at least a 10 millimeter increase from baseline, with superior to 10% of patients showing increase of more than 50 millimeter. So you have to optimize pharmacotherapy for control of baseline hypertension before treatment initiation, and you have to routinely monitor and begin appropriate medical therapy for incident hypertension in conjunction with patient's primary care provider. The bleeding risk, BTK inhibitors have a mechanism of action that, in fact, will do an inhibition of the aggregation of the platelets. So it is associated with predominantly minor bleeding, ecchymosis, and petechia in most patients, but it can go to major bleeding, and you have to be very careful, especially when they come, for example, to the emergency with severe headache, severe migraine. Be careful that the BTK inhibitor could have some major hemorrhage in 2 to 9% of the patient. So the mechanism is so to involve inhibition of BTK and other related TEC family kinase, which play an important role in platelet aggregation mediated via the collagen receptor glycoprotein. And okay. Okay. And the second problem is when you are with the BTK. So we talked about the cardiac problems, we talked about the bleeding problems. The second problem, the third problem that you can have is the infection. So infection of any grade occurs in more than 50 of patients receiving BTK inhibitors, and pneumonia is the most common observed. Opportunistic infections, and this is important, including Aspergillus and Pneumocystis jirovecii, have been reported. So when you have fever with someone taking BTK inhibitor, you should obtain a complete workup with an appropriate index of suspicion for opportunistic infection. In the case of severe infection, hold BTK inhibitor until a definitive diagnosis is determined and restart after the start of clinical improvement. And this is very important. You should provide clinically indicated vaccinations before treatment. And consider PGP prophylaxis for patients deemed at high risk for infection, which we didn't choose to do it. But if you think that these patients are at high risk of infection, please consider, in fact, to give them prophylaxis. Diarrhea, it's the most commonly adverse event, but this is very easily managed with supportive anti-mortality agent, and sometimes we decrease a little bit the dosing of diarrhea, or we temporarily hold the drug and then we can begin it again. Also, as a side effect, you can have fatigue and arthralgias and myalgias. So fatigue is commonly reported. And please avoid dose reductions for fatigue, and try to find another reason for the fatigue, like anemia or a lack of vitamin B1, B6, B12. And sometimes when you have really severe fatigue, consider drug holiday or dose reduction, but not in the first 6 months if you can. Arthralgia and myalgia are seen in up to 1/3 of the patient. They have been associated, in fact, with 40% of ibrutinib discontinuation in real-world data, which is not a small percentage in real-world data. And this is very important, in fact, to address. And when the patients come to the clinic, you have to ask them about the arthralgia and myalgias and try, in fact, to boost them to continue their treatment despite the arthralgia and myalgias, because it is important to continue our treatments in this kind of patients. Treatment flares of autoimmune cytopenias during the treatment of BTK inhibitors can be managed with short courses of corticosteroids or CD20 monoclonal antibody treatment, and most patients can continue BTK inhibitor therapy. You can also have BTK inhibitor-related skin manifestation, and they respond to topical corticosteroids, and textural changes in hair or nails that can be treated with biotin, which are a simple pill that you can give to your patients. And also special side effects that come a lot with acalabrutinib is the headaches, and they resolve with extended treatment, and they are often responsive, like all the migraines, to caffeine. And this is important. It's the impact, in fact, of BTK inhibitor dose modification and temporary interruption of therapy on clinical outcomes. And this is important, especially for us now in Lebanon, since we have limited access to all the drug. So given that many early secondary effects are likely to decrease in severity with time, a strategy in which low-grade toxicities are treated with expectant management and supportive care when possible is recommended. But those reductions or cessation of therapy within the first 6 months of treatment should be avoided as much as possible, since it will make you lose, in fact, the benefit of your treatment. So a conclusion, a thorough clinical history encompassing comorbidities is of the utmost importance when considering therapy for patients with CLL. So patients with arrhythmia or poorly controlled hypertension may do better with other treatment modalities, and we will talk about it now. Example, the BCL2 inhibition. Given the impressive efficacy of BTK inhibitor in the treatment of CLL, appropriate management of BTK inhibitor emergent toxicity is of critical importance, because this class will remain a mainstay of therapy for quite some time. What about, in fact, the other frontline treatment that we are using a lot, which is, in fact, the venetoclax, which is a BCL2 inhibitor. And here also, he had his approval in the study CLL14, which was an international open label randomized phase 3 trial, where they put the patient on a venetoclax with a 5-week ramp up from 20 to 400 milligram per day until reaching, in fact, a total dose of 400 milligrams per day. And this was to avoid, in fact, the tumor lysis syndrome, which is one of the side effects that we have to be very aware of in CLL patients whom we start on venetoclax. And they gave the obinutuzumab 1000 milligram day 1, 815 of cycle 1, and then 1000 milligram day 1 of cycles 2 to 6 versus chlorambucil plus obinutuzumab, which was the standard of care at that moment. So you can see here that the PFS with the 4-year follow-up is really in favor of venetoclax plus of the Venclexta plus the obinutuzumab versus, in fact, the chlorambucil versus with the venetoclax. But since we know that the venetoclax plus obinutuzumab is a fixed dose duration treatment, which was in fact was one of the arguments to begin a treatment, for example, with the patient with a fixed dose duration. After, in fact, a lot of follow-up, we can see that the patient with the detectable MRD after 12 months will recur very quickly. And I think one of our future direction will be to see if we should monitor our MRD, or if we have a detectable MRD at the end of the 12 months, should we continue with our treatment or just stop it like that, like in the study? And secondly, if we have bad prognostic implication like a TP53 or an IGHV unmutated, should we stop also at 12 months or continue our treatment more than the 12 months recommended by the fixed dose duration treatment? So this is the PFS by response status and MRD in peripheral blood at the end of treatment. And it's very clear that when you have an undetectable MRD, you will have the longest PFS versus the patients who will have a detectable MRD. The safety, the venetoclax plus obinutuzumab, we have the problems of the anti-CD20. So the infusion reaction, you have to make to be very careful about the infusion reaction. You have to be very careful about also all the monoclonal, the anti-CD20 monoclonal antibodies and the COVID. But now I think we are getting a small break from the COVID pandemic. But be careful because it does a lymphocyte depletion and it can give you a less immune response to the COVID. For the venetoclax, you have to be careful about the tumor lysis syndrome. Do not forget to ramp up, because if you have a tumor lysis syndrome, it will be very severe. And as you know, you can stratify your patient as having a low risk or intermediate risk or a high risk of tumor lysis syndrome. And depending on your stratification, you will hospitalize them or not. For example, if you want to assess the risk, low risk is when you have no bulky adenopathy and an absolute lymphocyte count inferior to 25,000. If you have an intermediate risk, you will have a bulky adenopathy and an absolute lymphocyte count superior to 25. High risk, it's bulky adenopathy superior to 10 or bulky adenopathy superior to 5 centimeters and an absolute lymphocyte count superior to 25,000. And if you are a low risk, you could ramp up as an outpatient, but with a oral hydration. And if you are an intermediate risk, you will ramp up also as an outpatient, but with oral hydration, allopurinol, of course, and a lab monitoring that is more efficient in time, every 6 to 8 hours. And if you are high risk, that you have in fact to hospitalize your patient, of course, because the risk of tumor lysis syndrome is high. And just a reminder that the tumor lysis syndrome can begin as soon as 8 hours after you begin, in fact, your treatment. So please be careful to ask for another set of calcium, phosphorus, magnesium, uric acid, CBC, another set of biochemical tests 8 hours after you initiate your treatment. And be also very cautious about instituting the allopurinol if you can 2 days before beginning, in fact, your treatment with the venetoclax. And if you have access, of course, to fast tech, the rasburicase, it's very good, but be careful not to use the rasburicase if you have any J6PD deficiency. And this is important if you are planning to use it, to have done this J6PD deficiency in our patient. So this could be a treatment algorithm for newly diagnosed CLL. So newly diagnosed CLL patients requiring therapy by the CLL criteria, you have to divide your patient very quickly into having without deletion 17p or TP53 deletion, or with deletion 17p or TP53 mutation. If they are without deletion 17p, we said that the only niche where you can use, in fact, FCR or, in fact, chemoimmunotherapy is when they are IGHV mutated fit, because the FCR could lead us, in fact, to a cure. And that's what MD Anderson published, in fact, in Blood, with a long retrospective study about the patient who received FCR. But also, if you cannot give the FCR, even if they are IGHV mutated, you can give also ibrutinib, venetoclax plus obinutuzumab, acalabrutinib plus or minus obinutuzumab. If you are IGHV mutated, unfit, or high CIRSE score, you have the same, in fact, options, but instead of FCR in the countries where you don't have access to the novel treatments, you can still use BR. We are not using it since we have access to ibrutinib and the venetoclax now. If the IGHV is unmutated, there is no benefit to use any chemoimmunotherapy, and you have to go or to ibrutinib or venetoclax plus obinutuzumab or acalabrutinib plus or minus obinutuzumab. And if you have a deletion of 17p, of course, you will go to ibrutinib plus or minus obinutuzumab, venetoclax plus obinutuzumab, acalabrutinib plus or minus obinutuzumab. So as you see, you have now multiple options for the treatment. And to choose your frontline treatment, you have to consider also all the comorbidities like the history of cardiac arrhythmia, the need of anticoagulation, difficult to control hypertension, and a diminished creatinine clearance, or a high-risk tumor burden with the risk of a TLS. And sometimes there are some centers, when you have a high risk of TLS, they do what we call a debulking before beginning the venetoclax, and you can debulk whether with a monoclonal antibody or also with a BTK inhibitor. So picking a BTK versus BCL2 inhibition strategy, BTK inhibitor, logistically, it's very easy, but it is an indefinite therapy. TLS is not of a concern. We have more of a cardiac risk. And personally, I favor more BTK inhibitor when I have a high-risk patient as a frontline treatment, whether they have a deletion 17p or TP53 mutation. For the BCL2 inhibitor, it's a cumbersome initiation because you have to do a 5-week ramp up to make sure that you don't have a tumor lysis syndrome. But it's a fixed duration until now, because I think in the future, we will treat more and more depending on the MRD negativity at the end of treatment. You have a risk of TLS, you have a GFR sensitivity, and we have a question mark if it is the best frontline treatment for high-risk patients. And I thank you for your attention. And I'm ready, of course, for any questions.
Thank you, Dr. Colette, for the excellent updates about the CLL. I think we have a lot of questions, but I think we keep it after the lecture of Dr. Fadi Farahat, our next lecture. Dr. Fadi Farahat, the president of the Cancer Research Group, Collaborative Group. He is the head of the Hematology Oncology Department, Hammoud Hospital, University Medical Center in Lebanon. And he will talk about expand your expectations of long-term treatment with Busilif. Please, Dr. Fadi, the floor is yours. Also, I see that we have Dr. Maha Manashi, the president of the Syrian Oncology Society, with us. If Vanessa, could you give her access to give any comments after the lecture of Dr. Farahat?
Thank you very much, Dr. Sami. Thank you, Colette. It was really outstanding. I think it's educational, and I saw that some of the attendees would like to have it registered. So if we can send it for them, if you allow. So today I will talk about how I manage patients with CML perspective from clinical practice. First of all, I would like to tell that one of our colleagues, Dr. Khalid Ibrahim, will be absent, the third speaker, because today Dr. Ghassan Hamoud, who is the founder of the Hamoud Hospital where we work, left us, Allah yarhamu, and since Dr. Khalid is a parent, so he cannot be with us. So Dr. Ghassan Hamoud was really a pioneer in South Lebanon. He was the first who started the dialysis, hemodialysis, kidney dialysis. He was the first to make a center of open heart surgery. And in his hospital was done, to my knowledge, the first heart transplantation. So really, he upgraded the level of medicine in this region. Allah yarhamu. Now I will talk about the CML. The CML is different than CLL. Since the development of the imatinib, we really could control the disease. So the idea was how to improve the treatment, or how to improve the results, and how to improve the tolerance of treatment. So the discussion usually is different. Here we'll go for review of the latest update of the ELN guidelines for CML management. Then after, we'll discuss some patients-related factors that may affect the choice of TKI, and we'll review the bosutinib, which is promising, in my opinion, as one of the future TKI inhibitors in the CML. We'll start with the ELN 2020. As you know very well, the difference between 2020 was that we used the SOCAL system, Euro and Autos prognostic system. Now we are using the ETLS score, and we are putting them into high and intermediate risk, which is different than what we have previously. The definition of treatment failure, usually we said if we have more than 10% of BCR-ABL transcript level at 6 months, we consider it failure. Now we say if you don't reach the transcript level BCR-ABL less than 10 at 3 months, so the patient is in failure. Initially, when we had the recommendation of the ELN 2013, there was no terminology, or there was no definition or role of the treatment-free remission. While now the TFR, the treatment-free remission, is included as a new significant goal of CML management. And the guidelines recommend consideration of TFR in appropriate patients after careful discussion, employing the concept of shared decision-making. What does it mean? Nowadays, we try to improve the treatment and the results and the major molecular response in order to stop the treatment, which means somehow, like if we are curing the patients, as you saw with Dr. Colette Hanna, patients who have a negative MRD after the treatment with the BTK inhibitors might have a plateau. So the question, are we nowadays curing the chronic leukemias in lymphoblastic, as Dr. Colette said, and in myelogenous leukemia? Because if any patient has the TFR acquired, we can postpone and stop the treatment. We'll come for it later. So the updated recommendation, in 2013, we had imatinib, dasatinib, nilotinib, first generation and second. And now we added the generic imatinib and bosutinib for the first line. And the update with including the generic imatinib, in my opinion, is important, because it's always a doubt. Can we use the first generation or not? And in our countries, we somehow are back using imatinib. And bosutinib, it was included in the first-line treatment recommendation based on the data that we will go through later on. In second line, we have imatinib, dasatinib, nilotinib, bosutinib. So bosutinib for patients who failed on imatinib, nilotinib, and ponatinib only recommended for patients who failed previous TKI and carry the well-known mutation, the T315I mutation. So what changed since 2013? So we have still imatinib, dasatinib, nilotinib, and bosutinib is now included as second line in patients with a prior TKI failure, resistance, or intolerance. And ponatinib is no longer a second line recommendation. So to select the patient, usually we have to decide what is our goal. And as we said, the TFR nowadays is important. So when I discuss with my patient, I tell him about the TFR, saying that in 2 years, if you are in deep response, we might stop it. The patient-related factors, the comorbidities, contraindication, and here you have to go and discuss with your patient about every medication, as it was shown by Dr. Colette, and efficacy versus safety as the driving factor. These are related to the study endpoint of interest that are in every trial. So we'll go through all of them. We know very well the imatinib. The recommendation are that there is no absolute contraindication and no life-threatening complication reported for imatinib. Still, it's the first generation, it's safe. Patient with low cardiac ejection fraction and low GFR should be monitored for related organ toxicity. So there is no real harm in this medication. The contraindication, hypersensitivity to the active substance, so that's the only contraindication. And when we go to the summary of recommendation on appropriate consideration based on patient comorbidities, we find that it's only the cardiovascular event and it's with limitation, and the renal impairment with limitation. So you have to look to these and say that imatinib as first generation, as per the ELN 2020 guidelines, is a safe and efficacious drug still to be used. We go to the dasatinib, and we see that there is a strong contraindication, the respiratory failure and the pleuropulmonary disease, concomitant or previous, and pericardial disease. And we know that the problem of effusion and these drugs is there. That's why it's a strong contraindication whenever you have a respiratory system problem or a pericardial effusion, you have to avoid it. And the contraindication is hypersensitivity as usual, specifically. And we go further to look to the to the summary of recommendation. And here we see that dasatinib has cardiovascular events as limitation, hypertension as limitation, lung disease as a strong contraindication, pulmonary arterial hypertension as limitation, pericardial disease a strong contraindication, autoimmune disorders, hypercholesteremia, it's like with some limitations. The other are okay concerning diabetes, pancreatitis, hepatotoxicity, diarrhea, and renal impairment. So discussing with your patient or deciding for your patient, you have to look to these, let's say, limitation or contraindication. What about the nilotinib? Nilotinib, we had a strong contraindication, the coronary heart disease, cerebrovascular accident, and peripheral arteriocclusive disease. Pancreatitis is also important. We know it very well from our experience. And a higher risk condition like hypertension, hypercholesterolemia, diabetes mellitus. So we have really some contraindication, and it's a major one. And we have some problems with the hypokalemia, hypomagnesemia, and long QT syndrome for the nilotinib. What about the, if we take it from another hand, so a strong contraindication will look to the cardiovascular events. So it's the only one with a strong contraindication here. And we have some limitation for hypertension, for hypercholesterolemia, diabetes, and hyperglycemia. So remember, you have to make a control of these of the cholesterol level and of the fast blood sugar, and some limitation for the hepatotoxicity. Okay, so these are the limitation. And remember, even in case of pancreas, it's not written here, but it's one of the contraindication if there is any history of pancreatitis. Then after we'll go to the bosutinib, where that's why it's interesting, where there is no relevant comorbidities or strong contraindication as per the 2020 ELN for the cardiac, hypertension, lung, pulmonary, pericardial, autoimmune, and hypercholesterolemia, no relevant restriction. Diabetes also, no relevant restrictions, important. Some limitation for pancreatitis, liver, and diarrhea. And I think it's affordable with these drugs. And the ELN 2020, again, the ponatinib, which is recommended beyond second line. It was in 2013 as second line, and then after it was pushed to the third line. So it's recommended post second line for patient who has the T315I mutation, which is present in some cases. And which is a problem, really. ELN recommendation on TKI contraindications only cover TKI agents approved for first line and therefore excluded ponatinib. That's why we don't have the strong recommendation for contraindication. But we look here, the summary of recommendation based on patient comorbidities, that we have a limitation for the cardiovascular, hypertension, hyperlipidemia, diabetes. So it's really mainly cardiac and diabetes in this section of treatment in the ponatinib TKI. So as we said, the ELN guidelines included recommendation on appropriate TKI considerations based on patient comorbidity, which is normal. That's that we just said. And the criteria for the choice of the second line are almost entirely patient-related and depend on factors such as age, comorbidities, and toxicity of the first TKI. In some cases, even if in the first line, you have to go and modify your treatment in order to get a second, a new line to avoid the toxicity. So we'll go now to the bosutinib, which is the newest arriving to the treatment market. So bosutinib is approved in EU, US, and Japan for CML and is recommended for first line and more as per the ELN. And this is based on some data that we have here. We have data for second line or more, the Beyond trial. And we have the before trial that has studied the bosutinib in first line. So before first line trial showed that the major molecular response and the complete cytological response rate are higher compared to imatinib. We would like to see a comparison with the second line, but here it's with imatinib. And we see that the MMR at 12 months is 47-36 to imatinib with significant p-value. So it was significantly higher for the MMR at 12 months and for the CCYR at 12 months. So the bosutinib in both MMR, CCYR was significantly, as you can see, the p-value higher controlling the disease. So the BCR-ABL1 more than 10 at 3 months. Remember again, now when we started, it was at 6 months. Now we have to reach 3 months control. We have to get a BCR-ABL1 less than 10% at 3 months in order to keep the same treatment. And we can see that here, what I'm saying. So if you have the at 3 months less than 10, you continue the same treatment. More than 10, you wait. And you monitor closely. And if it's not responding, you switch. Okay, more than 10 if confirmed with 1 or 3 months. So here you give yourself 1 to 2 months and you repeat it. Okay. For patient wishing to have the TFR, the discontinuation optimal response, the BCR-ABL should be less than 0.01, what we call MR4. We'll come back to it. So before the trial B4 at 3 months showed a higher level of responses. So it's better than imatinib by controlling the disease. And at 12 months in different risk scoring, we see that in different risk scoring, there is a benefit of the bosutinib. So the bosutinib in the B4 trial showed improvement in the disease control for all patients for different risk categories. The summary ALN will go again that there was no relevant comorbidities or strong contraindication for this medication, simply diarrhea that we are confronting in different treatment, which is easy to control, and some transaminase elevation, which is also seen in the first weeks. That's all. So the safety recommendation of the ALN are really in favoring favoring the bosutinib. Now, in the B4 trial, the treatment-related adverse event were high, NE1 98, 97 imatinib. The diarrhea was the highest, 70 compared to 34, and the others were almost the same, only the liver enzymes a bit higher. So it's important to say that the drug is safe. So here you have to check with your patient. For those who use imatinib, we know that there is a problem of the muscle spasm, which is really sometimes deteriorating the quality of life of the patient. Here we have 2% only. So as you see, you have to choose the toxicity profile when you choose the drug. Grade 3-4 treatment-related adverse event. So the ALT increased 19 compared to 2%, thrombocytopenia 14 compared to 6, and lipase and AST 10 compared to 5 and 2. So we have a myelotoxicity somehow, lipase and liver enzymes. And the data from the before study demonstrated low incidence of grade 3 cardiac, vascular, and hypertension adverse event, as you can see here in the gray color, 1.9, 1.1. So it's really, really low and non-significant. And the importance of the long-term toxicity is here, because we are talking about patients controlled for long-term and almost acute. So we have to check for the long-term toxicity, and we can see that really even with time, the new adverse event leading to discontinuation are still low. So it's a safe drug, and for all those who treated, you know that it's not a major problem, the toxicity for the long term. Now, again, the treatment summary, we have said that we have 18% versus 17 discontinuation, and almost the same number completed the 12 month of treatment. The adverse event is somehow higher in the bosutinib, but it's different, related to drug 12.7 versus 8.7. And what you have to look to, which is important, it's the suboptimal response. If you are aiming the TFR, here we have suboptimal response, and at 3 and 6 months, it's at 2% almost for 6%, so 3 times more. Is it important? Yes, it's important, but you have to talk about the toxicity, efficacy, and the economic toxicity, budget toxicity. So, here also we are showing the quality of life. So we can see that in gray we have patients who had some problems. We can see that for the mobility, it's equal. The self-care, it's almost intact. So the performance status will stay at 0. For the usual activities, pain, discomfort, and anxiety, it's almost the same in both, numerically less in bosutinib, but it's almost the same. Remember, we said again that we said already that MMR at 12 months was higher in the bosutinib, independently of the risk group. To conclude for the bosutinib, or for the presentation, we have to say that multiple tyrosine kinase inhibitors are recommended for the treatment of patients with chronic myeloid leukemia in both the first and second line. And data from the before trial, which is, in my opinion, the newest, demonstrate efficacy and safety with bosutinib versus imatinib in patients with a newly diagnosed Philadelphia chromosome CML in chronic phase. And in the absence of a clear recommendation for any particular second-generation TKI, patient-related factors should be considered when selecting treatment. Again, treating in hemato-oncology is not only, it's first about results, outcome, but it's also very important to choose your toxicity profile when you decide the treatment. For each treatment, for each patient, treatment might be different. So that's what we call personalized treatment. Updated 2020 ELN guidelines include recommendation on appropriate TKI consideration based on TKI contraindication and patient's comorbidity. So please, again, when you wish to prescribe such a treatment, you can go back and look to the ELN recommendation to choose the most adequate for your patient. Thank you very much. With that, I finish my presentation.
Thank you, Dr. Fadi, for the excellent lecture also. Now we have some questions, if you would like me or would like to take it. We have some question for Dr. Colette from Mustafa Khandakwi. What is the stage risk group of the CLL and what does that mean for me?
It means the classification, and stage 1, 2, 3 of Rai and Binet. If
yes.
you are probably when you most of the time when we are at stage 1 or 2, you won't have a criteria for treatment. But basically, we are still using the Rai and Binet classification for a simple prognosis that you do in the clinic, in fact. The implication for him is not super important, but no, it will be practically the same indications to treat, like anemia, thrombocytopenia, splenomegaly. So practically all our patients that we treat are a stage 3 patient. That's it.
Okay, the second question also from Dr. Mustafa. Which sample type is appropriate for FISH testing to determine if a patient has CLL, a cancer characterized by 3 copies of chromosome 12?
The FISH, you can do it on the peripheral blood very easily, especially if you have more than 5,000 lymphocyte count, which will be a clonal population, and you can do the FISH very easily on your peripheral blood, and it's very accurate. It's an easy technique, as you all know, because it's a probe that will, in fact, link to your deletion, for example, 17p or your 13q deletion. So it's a very easy way and elegant way to know about the abnormalities. And we should use it, especially since it does have a prognostic impact and a therapeutic implication.
Last question from Dr. Mustafa. Does Imbruvica affect kidney function?
No, not really. No, no, I don't have any. I didn't have any. In fact, patients. I don't know if you had, Dr. Farhad or Dr. Khatib, patients having a problem with Imbruvica. Not particularly. Of course, I never had to give it to someone who is under dialysis. So here I will have to read if we have to, when we can give it. But for the rest, I didn't have any problem.
We have new question. Do we need bone marrow study? I think you answered it, but do we need bone marrow study for diagnosis of CLL or CML?
For me, no. But in the ESMO guidelines and in the NCCN guidelines, they recommend to do a bone marrow biopsy if you have an unexplained cytopenia during the course of your disease, or if at the start you have an unexplained cytopenia that you can't relate to CLL. The other point is about the karyotype, and I think Dr. Farhad will answer for the CML. It's if you still want to have your karyotype. I think practically 95% of all the centers in the world are not using the karyotype really anymore as a prognostic factor for treatment. So for me, when I can avoid to do a bone marrow biopsy, which is invasive, costly, and not really easy to do, I will avoid to do it, in fact.
And for the CML, usually you have a high number of wide VCs. So in general, you can put the diagnosis even in CLL by taking from the peripheral blood. It might be enough. And also, as Dr. Colette said, for the CLL, the diagnosis doesn't need in general a bone marrow. Okay. But we usually do it in order to legal have a cover, especially in the CML, not CLL.
Dr. Maha, are you with us?
Hello. A very important point also is when you don't have on your peripheral blood on the flow cytometry a clear scar that indicates that you have a CLL, here it may be interesting to see if you can do a biopsy of a lymph node or a biopsy or a bone marrow biopsy, or to add some cluster differentiation on your peripheral blood, like the CD200, which is one of the new CDs that can make you differentiate with a marginal zone lymphoma. And of course, if you need to rule out a mantle cell lymphoma, which is the first differential diagnosis with CLL, you have to add cyclin D1. So you will need a bone marrow biopsy or a lymph node if you suspect that. So it will depend on your MATRI-test score.
And the answer for this question is at the moment of diagnosis, but sometimes we have to do bone marrow in later stages when we are facing a risk of transformation or when we have seen an accelerated phase. So yes, we have to do it. We have a question from Muna Grain. In case of patient CLL on BTK, he will undergo surgery. How many platelets unit transfusion will you give? So if the patients have thrombocytopenia, that's what you mean, Muna?
I think she means, no, if you have a minor surgery, you have to stop the BTK inhibitor 2 days before and 2 days after, and you don't have to give any platelets, in fact. If you have a major surgery, you have to stop them 7 days before by label of the product and 7 days after. And practically, you don't have to give platelets. It's not like the aspirin where we give platelets to give a new pool of platelets. And if during the surgery they have a major bleeding, it won't be a medical error to give platelets, of course, but it's not in our practice to give platelets when we are giving BTK inhibitor. You have to stop before and after.
Do you prefer to do the karyotype?
If I answered the question.
Yeah. Do you prefer to do the karyotype in CLL through the bone marrow or peripheral blood if you have a high number of white BCs?
I prefer not to do a bone marrow in CLL. That's why. So if they can make me a karyotype, if they have good metaphases in the peripheral blood, which is not really doable most of the times, I would do that. But really, practically in our clinical life, and we don't need the karyotype, in fact. So that's why I don't push for it.
You don't do it because you have alternative. Yeah. But if you don't have these alternatives, you have to do the bone marrow.
Yes, and we will have less and less alternatives. So maybe we will go back to the karyotype, the good old karyotype.
Can we treat CLL with RCVP in limited resources? If limited resources.
I don't think it will yield good results. I prefer bendamustine rituximab that will be the same cost, or FCR the same cost than RCVP, because it has a different indolent course than follicular lymphoma or than a marginal lymphoma. So for me, RCVP is dead completely for the CLL.
Okay. And finally, again, Mona saying that she knows a case of emergency surgery who's taking BTK. So as you said, Dr. Colette, if there is no abnormal number of platelets, there is no need for platelet transfusion. Do you agree?
I know what she means. If it is an emergent surgery, and even if you have a normal number of platelets, maybe she wants to give a new pool of platelets that won't be inhibited by the BTK inhibitor, like we think in aspirin. It's not a problem. She can give it. It won't give any side effects really, and she can give it. But still, she has to tell the surgeon that the operation will be very tricky because they bleed a lot.
Okay, I think with that we finished, Doctor. We don't have any more.
I would like to thank you, Dr. Colette, Dr. Fadi, with almost 85 participants from MENA region with us for the excellent lectures. Just to announce that our next activity will be next Tuesday, June 21st, and will be about the GU, session number 2, GU malignancies. So we are waiting for all of you to be with us next week. Dr. Fadi, wish you safe trip. Huh?
Thank you very much. Thank you. Thank you for the audience. Thank you, Dr. Colette. Thank you, Dr. Sami, Vanessa, and Sciences Pro. See you next week. Again, really, we have a big loss, Dr. Ghassan Hamoud, Allah yarhamu.
Allah yarhamu.
Who was one of the pioneers. So see you next week. Thank you very much.
Thank you. Bye.
No.